Chapter 18. Okay.
Isolated.
First thing about lifting, moving, and positioning a patient is body mechanics. The second thing is body alignment. Those are your two main concepts that you have to know about when you're lifting, moving, and positioning a patient. Body mechanics. Talk to me about what are some good body mechanic techniques.
Bending the knee.
Okay, lifting with your legs, not with your back. A wide base. When you go to bend, you bend from your knees. When you lift something heavy, do you carry it away from you or do you bring it into your core?
Bring
Bring it into your core. If you can't reach it, climb up onto a step stool or a ladder to get it down. You don't want to try and reach and tiptoe and have it fall on you. Positioning a patient. What's your most important thing when you position a patient?
Their alignment.
Alignment. So tell me what alignment looks like.
Keeping their spine and everything straight up with their head.
So what you always need to do is ears over shoulders, shoulders over hips, hips over knees, knees over toes. If your patient is like that, with the exception of course, if their knees are bent, I'm not talking about that, but you always need to keep that mantra in your head. Ears over shoulders, shoulders over hips, hips over knees, knees over toes. If you can do that, then your patient is in proper body alignment, and you're doing the best for your patient. And then you use the pillows, however you need to use the pillows to position them so that they stay in proper body alignment once we position them. Okay? All right. What's the number one, or what's the most common occupational disorder in nurses? Back injuries. Okay, this comes back to a lot of your CNA training, but when you get somebody out of the bed, how do you want to get them out of the bed? If they're weak, how are you going to get them out of the bed?
You're going to stand in front of them?
You're going to stand, you want them to scoot up to the bed until their feet are flat on the floor.
Is this number 3?
That's number 3.
Thank you.
Mm-hmm. You ought to thank Blondie over there, because she's the one who reminded me.
I know, she's got my back.
No, she threw you under the bus, girl.
What? Oh, these are my people now. Y'all need to be treating me right now.
Okay, what is the best way to transfer a patient who can stand but not ambulate? You have to transfer them from the chair to from the bed to a wheelchair. What's the best way to do it? Using what?
A gait belt. I'm sorry.
You can use your garter belt. I'll use my gait belt, and we'll see what you got on your mind, girl.
Okay. Is that called stand pivot?
It's a gait belt, yeah.
No, stand pivot is kind of when they can kind of gait belt.
So a gait belt. You want to use a gait belt, and then yes, you would do a pivot with them, a pivot turn, but you need to have that gait belt to hold on to so that as they pivot around, you have something to keep them stable.
They're never. I had a blue one.
Okay.
So it wouldn't be called a transfer. Are you putting this up tonight?
It might be called a transfer belt. A transfer belt, gait belt, they're the same thing.
Oh, okay.
Okay? Transfer belt, gait belt, they're the same thing.
And you use a gait belt when a person cannot
ambulate. They can stand, but they can't ambulate. So you're going to help them get out of bed and stand up using that gait belt. And where do you want to put that gait belt?
Around their waist.
Around their waist, like right over their belly button is where you want it, okay?
Over the belly button?
Yep. And how tight should you have it?
You can only put 2 fingers.
2 fingers. That's right.
2 fingers,
Here, Mike. So I can get that copy emailed to me just in case.
baby.
My email.
Oh, okay.
I'll just send it to you. You did it?
Okay.
Did you just send it just now? No.
The thing I should have already sent to you.
No, I haven't.
Make sure that as a new nurse or as a nurse and you're giving instructions to your aides about how to help get somebody out of bed, you want to be as specific as possible. So you want to say this patient is an assistive to using a mechanical lift. Okay, so the goal is to be as specific as possible when giving directions to unlicensed assisted personnel. What's passive range of motion?
It's when you're helping them.
That's when you're doing it for them.
Yeah.
Okay, and probably the person who would need passive range of motion the most would be a CVA patient.
CVA.
Patient with CVA, cerebral vascular accident, or a stroke.
Oh, I got it. Thank you.
Okay. What would be the best way or the best intervention for our patient? She's frail, she's elderly, and she is developing a pressure sore over her sacrum, and she won't stay sidelined. Every time you put her in a sideline position, she starts to roll back on her back. And you know she has a pressure ulcer on her sacrum, so what's the best thing to do?
Put a wedge, like the wedge there.
She'll roll back over it.
I put the bed in high power.
So the right answer would be to place the patient on her stomach using a small pillow below her diaphragm.
And this is to do for what?
This is for a patient that is frail, that is she's frail and elderly, and she has a pressure ulcer starting on her sacrum, but she won't stay in a side-lying position. She keeps rolling back onto her back. So how are we going to relieve her of that pressure so that she doesn't make it worse?
For a patient like that, just curious.
They don't have an
just
attachment.
put a pillow like behind their back and put them in like a high power.
You hear me?
Does that help?
Well,
I like
the pressure, but where is the pressure then?
Here, you want to use this?
Yeah.
Thank you. She's
Like wouldn't it just pressure on the lower bottom?
No, it puts it right on that tailbone, which is right where that sacrum is. Look, even now, if I'm sitting up, this is semifallus, right?
Yeah.
Okay? If I'm sitting up right here, all that pressure is right over my sacrum. It's relieved on the very bottom, but it's like my tailbone is right here on the chair.
Yeah.
That's where it is.
So even a pillow wouldn't help.
Now it's just a cushion. A cushion.
Turn on the side.
It's just cushioning. Yeah, but it's a cushion pressure. All right. What is the best way to raise somebody in, or put somebody in a Sims or lateral lying position?
What's the best way to do it?
Mm-hmm. Whenever you go to reposition somebody in bed, what's the best way for us to do it?
Using the actual undergarments on them, like the sheets and
Chuck.
stuff.
Okay, but before we use the chucks, what's the first thing we want to do?
Make sure
Lift
that
the
they're
bed.
aligned.
Raise the bed to waist level. Because the thing is you want to always protect your back. So whenever we are doing something in the bed, we always want to raise the bed to our waist level. And then we want to use whatever other appliances that we have that will help us move. So if there's a draw sheet or a chucks, we want to roll them and move that so that we're not actually moving the patient, and we want to be careful that we're not shearing that patient too, though. You know what I mean by shearing? Okay. Correct body alignment in the supine position. What would you do? Feet wise, what would be correct body alignment for the feet?
In front of, like,
How do we want the feet? Do we want them to be here?
We don't want them to
Dorsiflexion then is what you're telling me? We want the feet dorsiflexed, right? That's proper body alignment. In a supine, dorsiflex. Proper body alignment for supine position is dorsiflexion. What's one of the things? What's one of the first things that we want to do for our patients when we know that we have to get them out of bed and they've been on bed rest for a few days? What do we want to do?
Just let them sit on the bed for a while.
Dangle, exactly. We want to dangle them on the side of the bed for a while and let them kind of get their bearings, because literally their whole blood pressure has to change now, because they were they were laying flat, so they have hypotension. Then when they sit up, it takes a while for the blood pressure to go back up the way it needs to, all right?
Isn't that called orthoscopic hypertension?
Orthostatic hypotension.
Orthostatic.
Okay. Ooh, this is really good. Patient with right-sided weakness, where do you put the wheelchair?
On the strong side.
On the left side of the bed, exactly. Always.
Oh no, my dad.
This is hugely important, guys. You always want to put the wheelchair on the strong side of the patient. Okay?
I just downloaded it. Thank you. So it's right there. It's in your downloads. It's that long .pdf. Thank you.
Know what shearing is.
What is shearing?
Shearing is where you, it's a force that causes the skin and the sheet to rub against each other, and that can actually cause a bed sore on that patient if we are not careful. Okay?
What did you say before that? She handed it to me.
What did I say
put the
before?
wheelchair on the
strong side. Yeah.
Thank you.
Okay. Spinal surgery patients need to be positioned using log rolling. And what is log rolling, guys?
So you have like one person at the head, one person at the mid body, and one person at the feet, and you like count to 3 and make sure the whole body's rolled evenly.
Exactly. So that the knees and the spine and the feet all roll together as one. Okay? That's log rolling. And that's important for a spinal surgical patient.
Shay, trochanter roll.
Trochanter roll is the
need 3
roll
people for
that's
that?
in between the legs whenever somebody has, for hip surgery. It's also called an abductor pillow. Okay. Okay. What would be a good thing for our patient who has had a stroke? They have weakness, let's say right-sided weakness or paralysis, and we want to avoid contractures for them. What could we do for our patients to avoid contractures? Range of motion. What kind of equipment could we use for them to keep them from being contracted? Stress balls, and actually you laugh, but that is really good. But
Trapeze?
that's a trapeze, but what I'm thinking of is you can roll up a washcloth and put it in their hand to keep their hand open instead of being able to tighten up and close. So those are some of the things, using braces, a rolled up washcloth. A stress ball would even help, because you put that in there and it keeps them from contracting in on themselves, okay? So, hand splint. Okay. Why would we want to do passive range of motion on legs of somebody that had a stroke? What are we trying to prevent?
Muscle atrophy.
But specifically legs, we're trying to prevent contractures of the hips. That's why we want to do passive range of motion to the legs, is to prevent, because once those hips start to contract up, then we're going to have problems with gait and balance, and we're setting them up for some serious problems.
And passive is when we do it, right?
Exactly.
So passive range of motion to legs is to
Prevent hip fractures or hip contractures. All right, what do we do for our patient? We're walking with them. They said, I'm dizzy. I can't stand up anymore. and they begin to fall. What are we going to do?
Like, how do we
Ease
take
them
them
to the
down?
ground and soften them.
So we step behind the patient, we grab them at their waist because they're going to have a transfer belt on, because we know that prudent nurses use transfer belts when we ambulate, right? And then we allow them to slide down our leg gently onto the floor. Okay? How many times a day should we do should we have our patient do active range of motion?
Twice a day. 2 times a day.
As
Is
many
it one?
times as they can tolerate.
Yeah, cool.
Okay, what's the best way to help the patient ambulate? What's the first thing we're going to want to have that patient have? A gait belt or a transfer belt. Then how do we hold that transfer belt? That's right, behind them. We're going to hold it in the middle of that patient's back. I know, right? You know it. But we're gonna be behind them, behind their back, and right in the middle of their back, and that's how we're gonna help them walk. So that if there's an issue or they start to fall, we can quickly go behind them, let them slide down our legs. Okay?
All right.
Okay. You need principles of good body mechanics. We talked about. What is Fowler's position? What degree is Fowler's?
40 to 60.
60 to 90. 60 to 90. What happens to the elderly person as they age in their muscles? What happens to their muscles?
Start to atrophy.
They don't atrophy, but their muscle cells are lost. They don't have as many muscle cells. Okay? And their muscles are replaced by fat, which leads to loss of strength.
And what was the first one replaced by fat?
Muscle cells are lost or replaced by fat, and that leads to loss of strength. What are the two main factors in the development of pressure sores?
Not being turned.
Pressure and shearing force.
Pressure and shearing force.
Two main factors in the development of pressure ulcers. Pressure and shearing force.
Yeah, pressure and shearing force. That's the key.
What is the fluid-filled sac that allows the joint to move free?
Synovial sac.
Bursa. Bursa. Yep.
Bursa.
The fluid-filled sac that allows the joint to move freely is called a bursa.
Because a person gets bursitis because when you're popping the bursa.
Okay, 3 important complications that can happen due to incorrect alignment or positioning would be pressure ulcers, contractures, and fluid in the lungs.
Say that one more time.
3 important complications that can arise from incorrect alignment would be pressure ulcers, contractures, and fluid in the lungs.
And what was that?
What was what?
What was the? I got the 3 things. Pressure ulcer,
Oh,
contractures, and
it's
fluid.
complications from incorrect alignment and positioning.
Helping at all?
Yeah, feels really good.
I can't believe my hearing at this point.
Let's keep coaching the game, you know what I'm saying?
I cannot believe how many more chapters there are.
It's insane.
This is stupid. They should break it down more.
Huh?
Basically, we don't need to study the
Huh?
skills.
They should try to
So
break it
far,
down.
not yet. Just those little bits of skills that we talked about, like not so much the step-by-step of the skills, but the basics of the skills, like feels really good. like sterile technique,
Mm-hmm.
the how to prevent the breaking of sterility, like the 1-inch border, hands up above the waist, that kind of stuff.
We need to know that.
Yeah. Okay, moving on to chapter 19. Go back up to the top. Go back up here.
Up here?
Yeah. Oh my gosh. Okay, chapter 19. Sorry.
I'm thinking
I'm
about
sorry.
real fast.
Yeah.
I don't think we
Can we?
can. I don't think we can.
What, switch?
To online?
No.
Okay, chapter 19 is all about pressure sores. I keep wanting to say ulcers and sores at the same time, and it comes out all funky. But okay, here we go. It's okay. Sorry, you gotta stop because I'm like,
sorry.
no, it's okay. I'm like, okay, I'm jello right now. Cause
Yeah, okay, I'm done.
Yeah, okay, I'm done. I can't
Time to go
concentrate
home.
anymore. All right. Okay, what does an injury to the skin initially put the patient at risk for? Infection. Okay. Oh, okay. How does the skin cool down?
Sweat.
And
Evaporation.
okay, but what happens is that the body will dilate those blood vessels to bring the heat to the surface, right? That's why fair-skinned people get red, and then and then they start to sweat, and then it cools down. Okay, so if we know that our patient has been to physical therapy or been doing some kind of exercise or something like that that's making them hot, we don't want to stop that process because that's the body's natural way of cooling down. We just want to make sure that we recognize that that's what's happening is the patient's cooling down, and something else we may want to do is help to increase their fluids because we know fluids can help cool them down as well. Okay? I feel like I'm just telling you so much information right now. All right. When you are going to look at a patient and you think that they may have a pressure sore, what's the first step that gives us a clue that the skin's not broken, the skin is reddened, but what makes that area different than just an area that's been sat on too long? No? It's the fact that it doesn't blanch, or that it blanches. It doesn't blanch, rather. So, like, if I push down on my skin, it turns white and then it turns red. That's how I know that this is not a pressure sore happening. If I press down on it and it doesn't blanch, it just stays red, that means that circulation isn't coming to that area of the skin, and there's going to be a pressure sore happening. Okay, so that's called a non-blanchable area, and that's not good when it doesn't turn colors when you press down on it. Okay. And how would you chart something like that? Okay, but you can't ever say pressure sore. The doctor has to recognize that it's a pressure sore. And then you would want to, she would say non-blanchable area, but you would want to describe it. So you would want to say something like 2 centimeter by 3 centimeter non-blanchable reddened area to the coccyx or to the sacrum. Or you remember that, Michelle, from last week where you had to actually measure everything and write it down specifically? Yeah.
I'm not about measuring anything. I'm doing that. I'm like, too funny.
And I know you guys are going to be tired tomorrow, but I do
We have a
have
half day.
Wednesday. Oh, I'm sorry, it's Wednesday. Wednesday I do have I think we're going to be doing Foley catheterization and sterile gloving and stuff on Wednesday if you guys want to come.
And you guys, I think that we should bring it up. I have the calendar. We do not have a test next week. So,
One thing at a time.
yeah.
I would be good with that.
Considering she wasn't there for a couple days either.
And then we have half days. The days that she can lecture, they're half days.
Well, what do you really think she's gonna cover on Wednesday? One chapter?
Story time.
Yeah.
She gonna tell us about why she been out.
Yeah, and then how her grandson.
My grandson.
Okay, so
Somebody sneezed on me.
Nobody better not ask her how
Well,
she's
that's what I said. If she
feeling.
walked
Nobody
in, I was
better
gonna be
ask.
like, your dreams.
Reality is we don't care.
Yeah.
okay,
I don't want any of it.
what's the best way to take care of our frail elderly?
Oh wait, this is a video.
I know you didn't just get some food. Didn't even ask
I was
me,
thinking
bro.
about soup. I'm sitting here like,
What's up with that,
what kind of
man?
soup did everybody get?
Broccoli
Everybody got
and cheddar.
cheddar.
You didn't
It's
even
gas.
finish the soup,
I
so.
know. I'm just messing with you. Okay.
She
I'm
didn't like
sorry.
this
This is
soup.
all on video. I forgot.
See, I keep thinking about the video, you know what I'm saying?
I'm so sorry.
Leave me
That's gonna
alone.
be on YouTube now forever. Great.
What?
All right.
Her getting on to me.
So-
Food.
And
Oh shit.
yeah, I know. All of that's gonna be on YouTube.
You gotta edit this before you throw it online.
Wow.
She'll be like, oh,
Okay, so one thing that we need to remember, guys, is for our frail elderly patients, when we bathe them, we need to be super cautious of the temperature of the water. Okay, because too hot, we can burn them. Too cold, we can actually chill them. All right, so we want to be like Goldilocks and get it just right for them. Okay, and then we want to warm the room up before we undress them and get them into the bath. We want to make sure that we warm the room. Okay. Okay, and always remember that your patient may not have the same hygiene practices as you. So whereas you may want to take a bath every day, they may want to take a bath every week, okay? Or they may want to take a bath 2 times a day, and you may not want to take a bath 2 times a day. So you need to find a happy medium between what you want, what the patient wants, and what is appropriate for healthy. Okay? All right, and always make sure that we want to encourage our patients to use as much, to keep as much independence as they can when they're bathing themselves. Give them the cloth. If they have a weak side, give them the cloth on their strong side. And always make sure that they are bathing themselves. And how do we refer to their strong side or weak side? How do we refer to that? Do we say, oh, use your good side, not your bad side? What do we say to our patients? How do we refer to that? We refer to that as the affected or unaffected side. Okay? Oh.
Take my strong hand.
Yeah. Okay. Tell me somebody, describe to me somebody that would be at a high risk for pressure ulcer development.
Somebody bedridden.
Someone who's in supine position for a long amount of time. Someone who can't move themselves. What else?
Being pulled up.
Okay. What about somebody that's incontinent?
Oh, yeah.
Yeah. Of both urine and
stool.
yeah, and stool. Exactly. Okay. What is okay? If a person is curled up on in a side lying position, what part of the body is going to be at most risk of creating a pressure sore?
The side that they've been laying on.
Okay, but what's that called? You said the hips? What is the medical term for the hips? Ilium.
Ilium.
The ilium. Okay. Sacrum is their tailbone. Ilium is their hip bone. Scapula is their shoulder blades. Okay.
You said the sacrum was the
Hip bone.
No, sacrum was the tailbone.
Sacrum is the tailbone.
and what was the other one? Because I got ilium, sacrum,
And scapula. Okay. Can we stage a pressure ulcer that has eschar on it? First of all, what is eschar? It's that blackened dead tissue. It's like a black scab.
What'd you call it?
Okay.
Eschar. It's ESCHAR.
And that's stage
Yeah.
4.
Well, can you stage it though? It's got eschar tissue on it, but we can't really effectively stage it because we don't know what's going on underneath it.
It's unstable.
Yeah, it's unstageable. That's what you need to know.
What's unstable?
Anything that has eschar tissue on it is unstageable. Okay. If you notice that your patient has a reddened area on them and you move them, the appropriate intervention would be to go back in 30 to 45 minutes and reassess to see if that reddened area is still there or if it's disappeared. Okay? Okay, we've got oral care for an unconscious patient. What are we worried about? How are we going to put them in the bed?
On the side.
Side lying, and we're going to move the bed up to our height, put them in side lying, and then do oral care on them.
Is Sam sideline too or no?
No,
Oh no, that's okay.
yeah. Side lying is literally on your side with one hip up. What's wrong? Is it starting to die?
You have 23%. You're
Oh.
okay.
All right. How do you detect a pressure ulcer in people with dark pigment?
Dark pigment?
Yeah.
Doesn't it look lighter?
You're gonna look for a purplish hue underneath natural light. So you're gonna get as much natural light in the room as you can, and we're looking for a purplish hue underneath there.
When you say natural light, you mean like open the window?
Yeah, open the
Okay.
window, because fluorescent lights aren't gonna give you the same coloring.
Right.
What do we do for our patient that has dry, itchy dermatitis?
Make sure it stays moist.
Okay, what's something that we can give them that will help it? This is an old school remedy, an oatmeal bath.
Oatmeal bath?
An oatmeal bath. For, like, that's what you can do for people that have, of course, I think I told that to my husband one time, and he actually put oatmeal in the bathtub. And you're supposed to put oatmeal flour part, not the whole oatmeal itself. I came home and I was like, why is there oatmeal in the bathtub? He said, you said to give Haley an oatmeal bath. I said, oh my God, honey.
So oatmeal bath for dry skin.
Yes,
for effort, Rick.
yes, he was a good dad. He did exactly what I said.
It's not as bad as the honeymoon story.
I know, right?
Yeah.
But
That's
the
hilarious.
thing is that Haley was she 3?
Yeah.
She was
Maybe.
like 3, right?
Yeah.
You guys want him too?
Yeah. Yeah, that was enough.
Okay, how do you give a complete bed bath? Oh, well, just know how to give a bed bath. You know that you wash the eyes first without soap from the inside out, then the other corner from the inside out. You remember all those things? That's all here. Okay? All right. Uncircumcised male. How do you give pericare to him?
Pull the foreskin back.
Yes, and then once you've given care, make sure that you put it back up, okay? Because if you don't, no, seriously, if you don't, you can cause that to get gangrene. It really does. It works. It works like a rubber band, and it'll like keep the blood from flowing on to the tip of the penis, and then someone will hate you for life.
Not good.
Okay.
Oh my god.
All right. Oral care to people with dentures. Do you guys remember how to do oral care with dentures?
Take them out. You don't put them in hot water because it'll make them lose its shape.
Exactly. No hot water, no cold water. You want it just right, lukewarm. You're gonna remove them, clean them, and store them, especially at bedtime. Okay?
You don't. Do you store them in water? Do you store them in the room temperature
Water, yeah,
So you have to.
yeah. Because if not, they'll dry out and then they'll change shape.
Okay.
right. The nurse needs to make sure that they change their plan of care for people who are blind, for people who can't hear. You have to change that plan of care for that specific person, for that specific need. I feel like I've been ignoring this side of the table. I'm sorry.
It's okay. We're not the camera side. So you
Well,
just-
that's
Yeah.
I'm sorry.
Keep facing that way.
Yeah. We're good.
Okay, how you gonna wash the hair of somebody that has blood and dirt and stuff in their hair? How you gonna wash their hair?
Using a basin
Okay,
or the
Or the
little
water.
head thingy that they have.
okay, and so you're gonna remove those tangles by using alcohol or water on small sections of the hair, releasing or removing each little section of tangles and debris as you go along.
Alcohol and water.
And you're going to start at the scalp and work down to the ends of the strands. Okay. Always make sure that before you shave a male, that you check to see if they need, if they have any safety precautions in place. You know, like straight razors for somebody who's on Coumadin or any type of blood thinner. You need to use an electric razor, not a straight razor, that type of thing. And when you shave them, which way do you shave them?
South of Boston.
The direction of the hair growth. Yeah.
Hair growth, right?
Okay. When you do nail care to a patient, you need to make sure that you use an orange stick. Okay. Hands, you can use soap and lotion in between the fingers, but on the toes, you do not use soap. You do not use lotion in between the toes. Okay. And you only file nails, even toenails. You file them, but you cannot cut them.
Is that fingers and toes you got
Yep.
there?
Right?
Okay.
Okay.
How is the nurse going to remove a hard lens by hand?
Remove what?
A hard lens, contact lens. If the patient can't remove that contact lens for himself, how do we do it?
You should be wearing glasses.
Pin them down on the bed.
Well, but what if I wore contacts and I got into a bad accident on the way home, and I'm at the hospital and I can't get my contacts out?
Wash your
You better
hands
call your
first.
eye doctor.
And they actually have a lens suction cup.
What?
They do. It's a little tiny, like a little suction thing that you put in there, and it sucks
Just
the
sucks
lens
it
out.
out.
Mhm.
I could use that.
Okay.
What if they tied it there?
Okay. When do you apply suction during oral care to an unconscious patient? Why do we use suction?
They
To
can't
prevent the
spit it
person
out.
from aspirating.
Yeah, because they can't spit it out. So before it goes down and it is aspirated, or to keep it from collecting in the patient's mouth.
Wait, what do you mean by suction? I never even seen or heard
Oh,
or
and really, there's a Yonkers section. It's like this long, hard plastic tube that comes out and is kind of crooked in, and it looks like the little
when
You know when you go to the
Like
dentist?
when you
go to the dentist.
When you go to the dentist,
Yeah,
you
I
got
know what it is,
Like-
but
Yeah.
like
You've never seen what at like a
hospitals have
facility?
those? Or,
Yeah.
like, I've never even seen that.
Yeah, Yonkers. Ask.
That's pretty
It's called
cool.
a Yonkers. So ask the next time that you're on the floor what a Yonkers is. Okay. What is stage 1? Stage 1 pressure ulcer.
Oh, okay.
Read my mind. Yes, redness, non-blanching. Okay.
Please don't have nothing less stage 2 or 3.
Okay. So stage 2 would be a deep pink area of unblanchable skin. It's deep. It's going to have lesions, and it's going to be deeper. So there's going to be a break in the top layer of the skin. Okay.
They're like a blister.
It's gonna be a blister?
Wow.
Blister.
Okay. Culturally sensitive nurse care for a Muslim woman
Okay.
who has noticeable body odor as well as abundant underarm hair should use soap and water under the arms.
Okay.
Is there something that I don't know about that with Muslims and bathing?
Not that I know.
Okay, I'm like,
I
that
think I'm
is,
pretty clean.
that is, no, I mean, that is the weirdest question I've ever seen in my life.
So it just says you use soap and water when cleaning their underarms?
Yes, that's what it says. Because you're culturally sensitive.
Maybe
You're
it's
not
saying,
putting
maybe the
deodorant
arm hair,
on.
maybe the arm heel part, it's saying like don't
Are you
shave
guys
your
allowed
arm
to
hair.
use deodorant?
Yeah. Fuck.
I
I mean, I'm just saying. I've never heard of
I know.
anything.
Wait, what's
Well,
the
you
question
that's
again?
weird.
maybe they don't want you to point out like Robbie was saying. They don't want you to be like, God, your armpits are hairy.
Yeah, like leave.
Can you
leave the
shave
bush.
the
Let's
underarm?
buzz them up
Yeah.
a little bit.
I never heard of anything like that.
Okay,
In the
so
book said we can't cut any hair, right?
right.
Okay.
Well, we do like if they're going to surgery. Part of going to surgery is clipping them, but we clip it. Like if you have surgery in your peri area, we'll clip the hair there.
oh, okay.
Okay. Sorry, that question took me back a little bit. Okay. How are you gonna document?